ahead and get started. So first off, this is the novel SRS and SBRT session. I'm going to invite Mohammed Ali to come up. He's a radiation oncologist at the Peter MacCallum Cancer Center in Australia, and he's going to talk about SABR and SBRT for primary kidney cancer. Thanks, Mohammed.
Good afternoon, everyone. And first of all, thanks to the organizing committee for the invitation. And I would be talking about SABR for primary kidney cancer and emerging standard. No disclosures. For the primary localized kidney tumors, partial nephrectomy or radical nephrectomy is considered the standard of care. And in patients where the tumor is less than 5 centimeter, always partial nephrectomy is considered standard over radical nephrectomy because of improved renal function preservation and almost non-inferior clinical outcomes. In patients who are medically inoperable or high-risk patients for dialysis post-surgery, the other treatment options can be active surveillance or thermal ablation. But normally these two modalities are recommended for patients who have tumor size of less than 4 centimeter. If we look at the prospective data for kidney SABR, are more than a dozen, almost 14 clinical trial, phase 1 or phase 2 have reported the clinical outcome. And I will be touching base on the two trials from Peter Mac, which is Fast Track 1 and 2. Across these two trials, more than 100 patients were enrolled. For Fast Track, the tumor dose which was selected was 26 grain single fraction for targets which were less than 4 centimeter. And for tumors which are more than 4 centimeter, it was 42 grain 3 fractions. So in 2012, when Shankar was planning this trial, so there was no significant published data. So based on the radiobiological cell lines where the alpha beta ratio of 2.6 and 6.9 for the two cell lines, so he selected this because both of these regimens were iso-effective biologically. Fast Track 1 was a single institution phase 1 trial, and the main primary objective was the feasibility, which was defined as completion of treatment and also meeting all the dose constraints. So at one institution, 37 patients with median age of 78 and the mean and median tumor size around 5 centimeter were enrolled. And overall, all the patients had histological proven diagnosis of kidney tumors. 89% of the patients met the feasibility. Out of 4 patients, 2 patients didn't meet the organ at risk constraints, and the 1 patient died of pulmonary embolism before SABR, and 1 patient didn't complete the treatment because of the logistical reasons. So 33 patients who completed the treatment as planned. Only 1 patient had local progression at 2.5 years post-treatment, and rest of the patients remained free of local progression during the trial follow-up. If we look at the tolerability, overall the treatment was really well tolerated, with 78% of the patients experiencing grade 1-2 toxicity, and mainly it was fatigue or grade 1 abdominal wall pain. And there was only grade 1, grade 3 fatigue. There was no grade 4 or 5 toxicity. And the distant progression and the overall survival was quite good, around 90% at 2 years. So after this trial, we started the phase 2 non-randomized trial. It was a multi-institutional trial across 8 centers. 70 patients were enrolled in this one. Again, the same dose for 26 grade single or 42 grade 3 fractions. Older age group with median age in both groups around 75. And the tumor maximum dimensions was 3.3 in single fraction and 5.3 in the 3 fraction group. And if we look at the renal score, so renal score gives us the idea about the complexity of the tumor. And higher the complexity score, there are less chances of successful partial nephrectomy. And most of the time, the treatment would be radical nephrectomy, ended up with more loss of renal function. So in this trial, more than 2/3 of the patients had a high complexity score, so there was no other nephron sparing approach apart from SABR. The trial median follow-up was 43 months, and again the toxicity is similar like Fast Track 1, 74% patients experiencing grade 1 and 2 toxicities, 10% experience grade 3. Out of these 10%, 2 patients experienced large bowel stricture and underwent surgery for it. Overall, there was no local failure, there was no cancer-related death, and 99% freedom from distant failure at last follow-up. So if we look at both of these trials, out of 103, 1 patient had a local progression. The best thing which happened to the kidney saver was the international collaboration under the umbrella of IROC. And since their inauguration in 2014, they have come up with multiple publications. So these are the two brains behind this collaboration, Simon and Shankar, and they started this in 2014. Recently, our last recent project was the 5-year clinical outcomes. So in this one, 190 patients across 12 institutions with median age of 74 years and the mean tumor size of 4.2 centimeter. So all this cohort, the median follow-up was 5 years. Again, well-tolerated treatment with 1/3 of the patients experiencing grade 1 and 2 toxicity, and 1 patient had grade 4 acute gastritis and then went on to have grade 4 duodenal injury at 16 months, but recovered from these side effects and was alive at 9 years without any progression. At last follow-up, the local failure 5.5 and distant failure of 10.8%, and it was expected like 10% of the distant failure because of majority patients being stage 1 and stage 2. And cancer-specific survival was 92% at 5 years. Recently, on the umbrella, on the ISRS, we did the guidelines and we did a systematic review of 36 studies, 822 patients, and the median local control was 94%, and the grade 3-4 toxicity was 3.4%. So if we look at overall, all these studies have shown very excellent local control and minimal toxicity with grade 3-4 toxicity of less than 10%. However, whenever we are managing kidney tumors, the most important thing is preserving the renal functions. And because we know from the studies that progressive kidney disease is associated with more mortality. So these are the two curves from IROC 5-year and the TROG Fast Track 2 data. So if we look at the median baseline GFR is around 60, so it means half of the patients had baseline chronic kidney disease of 3 or worse. And in both cohorts, there was identical decline. There was a steep decline up till 2 years, 10 and 14 ml. And after the 2 years, there was a stability, and the ongoing decline was mainly related to aging and other ones. So SAVOR result in new baseline roughly at 2 years. And across these two cohorts of 260 patients, total 8 patients underwent dialysis. Treating solitary kidney tumors with the SAVOR. So this is one IROC which is currently under review at European Urology. So in this one, we can see the identical decline at 2 years, almost 10 ml in the both cohorts. And also the dialysis rate was less than 4% irrespective of solitary or bilateral kidney. So in selective patients with solitary kidney and having a tumor in it, we can safely treat with avoiding the dialysis. Is there any dose response, or we can predict what will be the loss of renal function? So this is the analysis from 2016 for Fast Track 1 cohort. And what they have found is, like with even single fraction or multifraction, there is a continuous increasing decline in the renal function with increasing dose, but at certain point it just plateau off. And if we convert into BED based on alpha beta ratio of 3, up till 100 grade, there is a continuous decline and then plateau. So in order to preserve the renal function, we need to try to keep the BED 100, spare the normal kidney from BED 100. And in the same analysis, we found that 50% of the isodose correlate with the GFR loss in the follow-up. So while we are planning the kidney saver, the important thing is we should try to minimize 50% isodose across to the renal parenchyma. More the normal renal parenchyma getting less than 50%, we can preserve the renal function. This is one of our patients treated with 26 grain single fraction for right lower pole single kidney tumor. And this one is the renal scan after 2 years, and we can see the upper 2/3 of the kidney is completely functional, and there is complete loss of function in the lower pole, which corresponds to 50% isodose lines. So far, it is excellent, excellent tumor control, excellent renal function, but there are some challenges in kidney saver as well, and the most important one is the response assessment. And if we look at David Palmer, he was in Melbourne last year and giving a talk on lung saver, and he called it as a dark side of saver. And it's typical for liver saver, lung saver, and even in brain. Like, we don't know what is happening with the tumor. It's not progressing, but whether it will not progress forever. Following kidney saver, the best response is failure to local progression. There are 2 trials, small number of patients, but 4 important things which we can see. We can see most of the tumors are with the stable disease falling between progressive and partial. Very few patients can have an ongoing long-term partial response. Rarely we will see any CR. But the one important factor, which is the pseudo-progression, we can see some of the patients early on, they can have a slight progression of the disease and then started to have regression with longer follow-up. So 1/3 of the patients roughly can have pseudo-progression at first follow-up scan. Can we do the biopsy? It was common practice being done in 1980s and 90s for prostate, cervix, and some head and neck patients, and it was abandoned because of no correlation in the long term. So can we do it in kidney saver? So one study from UTSW, 16 patients treated with 3 or 5 fraction saver, and all the patients had a biopsy at 1 year. There was no complete response, though there was some hyalinization, necrosis consistent with some response. And when they did the molecular analysis, Ki67 and P16, it was consistent that all the tumor have lost the ability to divide and consistent with radiation-induced cellular senescence. And radiologically, when they correlated, so all the tumors pre-saver were having a continuous growth, and after the saver, apart from one, all the 15 tumor, they started to have stability of the growth or having a decline in the growth. So again, biopsy doesn't correlate with the radiological response as well. Contrast enhancement, which is used for thermal ablation, cryo, RFA, or microwave. But in saver, we can see that rather than having a decline in contrast, there is increased contrast enhancement. And again, out of these 41 patients, 3 patients had progression, but most of the patients have stable or partial response. So contrast enhancement can persist quite longer after saver. So this is another thing which we can't consider as a response or progression. So from ISRS practice guideline, we recommend that post-saver biopsy should not be considered off trial. Still, size-based RECIST is the standard of care, but it is imperfect. Try to avoid early 3 to 4 monthly scan because of pseudoprogression, and contrast enhancement is not recommended to evaluate response. What is the future trials which are looking at some new indications for saver? So as we all know, there are almost more than 10 clinical trials, adjuvant trials for RCC with tyrosine kinase inhibitors or IO, and most of the trials were negative apart from one, Keynote 564, which have shown some improved overall survival. And currently NCCN and the European, they recommend selective patients can be offered adjuvant IO. So can we do something different by giving neoadjuvant saver plus minus pembro to initiate some immune response? So this is one trial which is going on at Peter Mac. So currently we have 2 patients short of the accrual, and expecting complete next month, and will be presenting some results end of the year or early next year. Then cytoreductive SABR in some tumor sites like NPC and the prostate, there is improved survival by giving radiation to the local disease. So CytoShrike and Samurai are the two trials looking at giving systemic treatment plus minus SABR to the local primary disease, and progression-free survival is the endpoint. So both of these trials are enrolling. IROC prospective registry is getting the data for the prospective patients active at 6 sites, and we are expecting to open 40 to 60 sites by end of this year. And within 1 year, we already have 100 patients with prospective data on the registry. Current guidelines, SABR, in the European urology, they have used SABR in an umbrella term of tumor ablation and recommended not to use it for tumors more than 3 centimeters. And for NCCN, it is recommended as a category 2B and 3 for stage 1, 2, and 3 tumors. Just the last 2 slides, if comparing SABR with the thermal ablation. So thermal ablation is considered a strong recommendation by the guidelines, but we don't have any prospective data. We have a limit of size and also the limit of location, and it is invasive. But despite having proof of burden towards SABR, still we don't have a good recognition in the current guidelines. And if we, at the European urology, they have recommended not to use it for tumors which are more than 3 centimeters, but all the prospective data is for larger tumors where they are more than 4 centimeters. So I think we need more representation on the current guidelines so that we can try to advocate for our specialty. So in conclusion, multidisciplinary team is the required for renal cell cancer management, including radiation oncologists. We have the evidence that SABR should be the standard of care in medically inoperable patients. Acceptable renal function decline, despite having elderly patients with median age of late 70s, and most of these patients have baseline poor renal function. Failure to local progression is considered success. However, we need better ways to define the response and encourage patients to enroll on the trial so that we can get new evidence and new indications for SABR. And bottom line, RCC is not radio-resistant, particularly to higher dose per fractions. Thank you very much. Questions now?
I think everyone has very different topics, so we'll open up to questions for Dr. Ali. Any questions?
Hey, how are you? Thank you for the excellent talk. David Bion from NYU. I started using, kidney SABR more often once Anand Madhavan joined our practice a couple years ago, and really validated by Fast Track 2. It's more of a clinical question. I've seen rarely, and this was noted on the trial, that there is transient but severe flank or abdominal discomfort right after treatment or during the course of treatment. So in the discussion session, you guys discussed that maybe it's reasonable to prophylactically start giving these patients low dose of dexamethasone. Is that your clinical practice?
Yes.
Your guidance on that?
So at Peter Mac, what we use, we give 4 milligram dexa pre-radiation, and our grade 1 to flank pain is less than 10% at the moment. So all of our patients for kidney SABR, they get 4 milligram dexa pre-med. Yeah.
Thank you. That
Thank
was
you.
an excellent presentation. Oh, no, I have a question for you.
Oh.
I will keep you up here. I was wondering what kind of motion management you use for these patients.
So we are clinic-based, and we are using free breathing or free breathing gating or exhale breath hold. So we start with the 4D CT and assess the movement. And based on our data, we have seen if it's less than 1 centimeter, there is no clinical benefit of renal function preservation by managing motion. And if it's more than 1 centimeter, then depending on the patients, whether we can do the free breathing gating or we can do the exhale breath hold. And most of these patients, unfortunately, are elderly patients, not a good candidate for prolonging the treatment. So 2/3 of the patients normally end up with getting the treatment with free breathing, and very rarely we do the free breathing gating. And if we look, Shankar presented a data back in almost like 10 years ago, and based on 74 patients with 4D CT, the median movement was around 7 millimeter. Okay, thank you.
All right, well now, if no other questions for Dr. Ali, then we'll move on to Dr. David Gunn, who's a radiation oncologist at NYU Langone Medical Center, and so he's right down the street. And we'll ask him to come up to this podium.
Thank you so much for the invitation to speak today. It's an honor to speak in front of ISRS committee. When I was posited with this question of novel SBRT or SABR target, I treat mostly prostate. So how do we think about in an innovative way approaching targeting of a known entity, or perhaps avoiding a target? So this kind of illustrates a roadmap for where we'll be heading down over the next 15 minutes. This is my disclosure statement. So as we know, I imagine a lot of folks were asked through 2023, where PACE-B 5-year outcome data, a phase 3 randomized non-inferiority trial comparing moderate hypofract and conventional fractional radiation versus ultra hypofractionated radiation 3625 in 5 with 40 grade to the CTV. This was mostly a favorable intermediate risk prostate cancer cohort with no ADT allowed. As you can see here, at 5-year follow-up, SBRT, we're at 95.8% biochemical progression-free survival rate, which is quite impressive. But do we kind of pack up and go home at this point? What are the next steps as we think about as we approach further and further improvement in disease control? What can we do to improve our patients' quality of life? So as you see here, it's a dose cloud from our treatment planning system of a 40 gray SBRT and 5 fraction treatment. So as you see, homogeneous. Some lesser dose around the urethra region as you see here. But given that we are having optimal disease control, I believe that, and I think a lot of folks in the room believe that there has to be selective targeting to the highest risk region now that we have achieved optimal disease control while proactively preserving quality of life, namely urinary function, GI function, as well as sexual health function. So where do we kind of gain some evidence of and comfort for taking this approach? Of course, we're all familiar with FLAME phase 3 trial from the Dutch and the Belgium group, where they compared or where they looked into conventional fractionation with simultaneous integrated boost to what they call multiparametric MR detected or visible lesion that was contoured with 5-year biochemical disease-free survival, which was quite impressive with comparable late GU and GI toxicity reported. And the image on your right, you see a T2 axial image with hypointensity that was defined as the MR visible lesion. This was prior to PIRAD version 2 release, so there was no real strict guidance on how to identify these lesions per se. Right next to it, you're seeing a ADC map of the lesion again. Less signal, low ADC, and some K-trans information, and then dose cloud overlying it. So quite impressive and very promising in terms of further dose escalation to these higher risk regions, resulting in better disease control. Of course, next step was hypoflames to assess this question in a more of a hypofractionated approach, 35 gray and 5 fractions to prostate. This was a phase 2 non-randomized trial with 50 gray SIB, again to the MR visible lesions with median mean dose of 44.7. with acceptable amounts of grade 2 GU toxicity at 34 and GI of 5, and no acute grade 3 GU and GI toxicity reported, which was reassuring. And we eagerly await in terms of the secondary endpoint of disease control. So if we intend to de-escalate to the rest of the prostate, excluding the MR visible lesion, where we should be escalating for the benefit of quality of life preservation, I believe that it's critical, and I think you agree that it's critical that we define these DILs appropriately. Of course, we have PIRADS, version 2, to guide us in a specific way, but without in-depth training in terms of how to read these multiparametric MRIs, if you're not a high volume center, how do we truly know with confidence that we are targeting the extent of disease that we need to target? And we believe that for critical success of pursuing those de-escalation, it is imperative that we define what we call dominant intraprostatic lesions precisely and accurately. Now, this is work from Michael Zalewski while he was at Sloan Kettering, which was a routine 2-year, and retrospective routine 2-year post-SBRT biopsy where they dosed it to 40 gray in 5 fractions. Around 60% of patients ended up having positive local recurrence upon routine biopsy. Of those, 90% of the patients had history of PIRADS 4-5 DILs under initial multiparametric MRI, and 75% of whom had positive biopsies within that DIL. So that really highlights that and this is our approach at NYU, is to direct this dose escalation to these high-risk PIRADS 4-5 lesions, with the special assistance, I would say, from our radiology colleagues, because there appears to be, based on the FLAME post-hoc analysis, in terms of variability in how we define and delineate intraprostatic tumors at the time of contouring by the radiation oncologist. As you see here, this is paper from the folks who put together FLAME. Red that you see here, so this is patient 1, patient 2, and patient 3. These are 2 rows because, as you see here, red was defined by radiation oncology with assistance from a radiologist. But it appears to have missed where that DIL should have been when it was reviewed by an expert uroradiologist. Same here. Maybe there should have been a greater extent of targeting into that region. Here, maybe it wasn't as big as it needed to go based on expert review. So at NYU, we believe that, I again believe that many folks agree here that success of selective dose escalation and de-escalation approach in the future will depend on reliable MRI interpretation and segmentation of the DIL. So what we have done over the past couple months, in collaboration with our expert uroradiologist, create a seamless workflow to integrate their assistance into delineation of these targets using multiparametric MRIs. And of course, there's substantial logistical barriers, as you could imagine. Now, taking a step back, this is what we see when we see a patient in the clinic. And there might be some annotation that you see on PACS of the general region of where that DIL may be. And of course, we refer back to the accompanying MRI narrative report of the side of the DIL, where in the plane, level of the prostate, is it mid-gland, is it apex, is extending from base to apex, and where the zone of that disease is. So it really is dependent. So we know, around where we are supposed to be targeting, but what is the extent of the disease that we need to target? So our group, what we have done, utilizing our electromedical records, just as we would order an MR sim, just as we would order a diagnostic MR, we have created an EPIC order, that's our EMR, where we flag our radiology colleagues to say, hey, there's an MR sim that was completed, or there's a diagnostic MRI that was completed. Do you mind helping us? And this is not a phone call, this is not an email. At this point, it goes into their clinical queue, their work list, so it's seamlessly integrated, so they know, oh, these are MR, DIL, targeted segmentation that we need to help out radiation oncologists with, and then they'll place these these segmentations. And, obviously we don't want to impose on them to, come into our treatment planning system, contour together, and, they're just very cumbersome. So, we try to minimize their workload to have them just utilize what they're used to on their packs. And then we'll have a Python-based auto processing workflow where we would extract this information as it comes into our contouring platform or MIM, convert it into RT structure, RT-Struct DICOM for us to utilize it as a crutch, right? So we're not, taking their, contours as is, but we look at their contours, we look back at their report and their initial MRI, and, to our best clinical assessment, delineate these targets, as you see here. So it's been working wonderfully over the past couple months. So, we've launched our, 1.5 Tesla MR Linac program back in August. Really kind of picked up steam in October, and at this point we've treated 100 patients, over 500 total fractions delivered, and we are true believers in full adaptation during daily radiation treatment. And as you can see here, a big focus of our program this is an area that's been growing rapidly, to increase our focus on selective dose escalation to DIL treatments, i.e. SIB to those PIRADS 4-5 lesions. However, as we are pushing the doses more and more frequently, there needs to be an easier process of defining critical OARs, and with MRI guidance at time of MR sim, as well as adaptive treatment process during daily delivery of these treatments, we have more information than we have ever had to understand the substructures, delineate these targets, and try to constrain those areas to high dose radiation at time of delivery. So a quick example: urethra and bladder neck. I know this has been a conversation that's been ongoing, from brachytherapy to CT-based Linac SBRT treatment delivery. But here on our MR simulator 1.5 Tesla, without a Foley at this point, we're able to clearly define the urethra as well as clearly define that bladder neck, where we do our best to avoid high dose exposure to these, what we believe, a very critical region of the bladder or the lower urinary tract anatomy. Now, this is readily convertible onto our MR Linac platform on the 1.5 Tesla, urethra there, bladder neck there, and that's spacer. Another example, not as, I would say, clear cut as the MR sim, but it's enough data for us to really delineate that without putting patients to, through placement of Foley catheters at this point. Bladder neck again. Wrapping up our discussion in terms of avoiding critical targets, if you will, we utilize MR angiograms as our standard of care clinical practice at this point at time of MR sim, where we acquire this sequence at the end of simulation, where I believe, when I talk to our radiologists, of course they read this day in and day out, so they have great ease of understanding where these critical structures that innervate and provide blood supply to critical erectile tissues. But for us, I think there's still a lot of variability on how we interpret MRI. You don't have formalized training when it comes to, especially when it comes to MRI. So, utilizing or creating a workflow to help us visualize as easy as possible, define and delineate the internal pudendal arteries, bilateral internal pudendal arteries, has been of great help for our clinicians. For optimizing our workflow. And you see here, you see a maximal intensity projection in the sagittal plane of the internal pudendal arteries, as you see here, innervating or going into supplying the penile bulbs. And this is a video of fusion of AXT2 anatomic scan with the MR angiogram, and this is non-contrast based MR angiogram, so you can see it very nicely defined, makes our job much easier as we go through our contouring workflow. But can we aid non-diagnosticians like ourselves in better visualizing more than the IPA? Can we visualize the neurovascular bundle easier? We could still see it on AXT2, but can we do it easier? And the venous plexi around the prostate itself, is there any way for us to better differentiate that? So this is what we've been working with one of our great partners from Philips, Alex Dresner, and our radiation physics resident, Sarah Morris. We optimize a STIR sequence, fat suppression sequence, to help us visualize the internal pudendal arteries as we go down here, coming into view around here, as well as the neurovascular bundle to a certain degree, and mostly some of the Santorinus plexus, or the prosthetic venous plexi that we see around the prostate. Now, I think the biggest kind of benefit of this is to help us better provide contrast at the prostatic capsular margin for improved CTV delineation. Often I see folks, residents, other colleagues, over contour the prostate gland itself. So, in a way, I think it could be a crutch for us to prevent over contouring of these glands. And this is some of the parameters that we utilize at this point for STIR, and it's still kind of ongoing a research project. So here's my concluding thoughts. So whole gland directed SBRT is a highly effective treatment option as a standard of care for, especially in favor of intermediate risk prostate cancer at this point. I think there's room and promising room for de-escalation to areas that may not be as high of a risk for preservation of quality of life. And I believe this is a logical step forward for our field. Accurate and precise delineation of DIL will be critical for in maintaining outstanding rates of tumor control, or continued maintenance of outstanding rates of tumor control. And of course, ease of defining these high priority OAR substructures will be essential in our attempts to proactively preserve quality of life in our prostate cancer patients moving forward. So future directions at NYU, we have opened up a, how we are contributing to de-escalating treatment for our prostate cancer patients. Led by Michael Zalewski, we have opened a phase 3 trial, SBRT, unfavored intermediate risk patients. Decipher is required, randomized to 40 gray on an MR or CT-based LINAC alone versus more the standard approach of 40 gray with hormone therapy, with PSA, multiplexer MRI, and biopsy on the back end. We are almost ready to open up a phase 2 in intermediate risk patients with PIRATS 4 or 5 disease, where we escalate to 45 gray in 5 and de-escalate the rest of the prostate to 30 gray in 5 on the MR LINAC, with primary endpoint being 24-month biopsy positive rates and late grade 3 toxicity. And right behind that, we have a local radio-recurrent disease, DIL on MR or PSMA PET, we call it DRIL, dominant radio-recurrent intraprostatic lesion on MR and PSMA detected, where we do a step below what we do with the upfront setting SBRTs, where we do 40 gray to the DRIL and then 25 to the prostate, again on MR LINAC, with primary endpoint of late grade 3 toxicity, and again on the back end, 24-month biopsy for the patients enrolled in this clinical trial. And there's some images that I captured that are based on some of the contouring guidelines that we have developed here. So thank you, and I'll conclude my discussion there.
Time for one question. Anyone?
Thank you.
I'm going to introduce Michael Schulter. He's professor and vice chair of the Department of Neurosurgery and is also director of the Brain Tumor Center at Northwell, as well as co-director for the Center's Hair Tech Neurosurgery, also at Northwell.
Thank you, Dr. Chow, and I'd like to thank the committee, the ISRS, for the chance to close out the scientific program of this year's meeting. For you American football fans out there, I feel like Brock Purdy, things worked out okay for him, I would say. So I'd like to talk about the role of stereotactic radiosurgery for functional disorders in an era of deep brain stimulation and focused ultrasound. That's just a map of the Northwell Health System. It spans a big area of the New York City metropolitan area, focused primarily on Long Island, not exclusively. Those are my disclosures, nothing really relevant. So it's not a novel topic as such, but rather than the sort of pessimistic Greek philosophy of Ecclesiastes, nothing new under the sun, I like to say, everything old is new again when it comes to lesioning in the brain. And it's worth pointing out that stereotactic radiosurgery, like most other innovations in radiosurgery done by a neurosurgeon, of course, was invented by Lars Leksell, a neurosurgeon, and for the express purpose of doing what we now call functional neurosurgery or radiosurgery on the lower left. That's a colorized version of the famous first patient, the so-called orthovoltage guy, who is amongst a small cohort of people being treated for trigeminal neuralgia. You can't talk about functional neurosurgery in general, including radiosurgery, without some discussion of history. So very quickly, stereotaxis began in 1908 with the invention of the stereotactic frame. The word was coined by Victor Horsley and Robert Clark for the purpose of animal experimentation in the cerebellum. That's the original frame. I took a photograph at the European Stereotactic Society in 2000. It took 39 years before the frame was adapted for human surgical use by Ernst Spiegel, a neurologist, and Henry Weisses, a neurosurgeon at Temple University in Philadelphia. And again, this was for doing functional lesioning in the diencephalon for a variety of diagnoses. Movement disorders, in particular Parkinson's disease, but also psychiatric disorders, some people with pain, and so on. And this led to a boom in functional neurosurgery. Again, this meant lesioning, usually with radio frequency, but with some use of chemical lesioning in the diencephalon, debates, thalamus, basal ganglia, and so on. But 20 years after Spiegel and Weisses began doing this, and with this big boom, L-DOPA was found, and its analogs was found to be a treatment for people with Parkinson's disease. And that somehow seemed to be advancing automatically, but that led to functional neurosurgery cratering. It almost disappeared for about 20 years. But what happened was about 20 years after L-DOPA was introduced, the side effects of chronic L-DOPA therapy for people with Parkinson's disease became understood, and those were dyskinesias, on-off periods of medication. So the era of lesioning for movement disorders and functional lesioning was kind of rediscovered. Here's Lars Leksell's name again, the procedure that he had devised, the pallidotomy, then the posteroventral globus pallidus. In turn, it was, quote, rediscovered by Lori Leitonen in Sweden with the assistants, as you can see here, Marwan Hariz, who just recently retired, but these are all icons of functional neurosurgery of the last 50 years. So what changed after that was that beginning in the late 1980s with the work of Alim Benabid in Grenoble in France, and then others joining in, deep brain stimulation was found to be an equally effective and arguably safer way of treating people with, again, a variety of functional disorders, but let's just focus on movement disorders, in particular tremor, for the purposes of this discussion. And this paper in 2008 by Rick Sherman from Holland showed that while the efficacy of thalamotomy, of making a lesion in the thalamus, and deep brain stimulation was similar, the complications, unsurprisingly, of deep brain stimulation were much fewer than if you made a lesion. Because you put in a deep brain stimulating electrode, you're not damaging the brain as such, whereas when you make a lesion, you're explicitly setting out to damage the brain to achieve your result. The DBS system is also adjustable in a disease that tends to be progressive or changes over time, and it's reversible for whatever reason you need to stop it completely. What was found, however, over time was that when you did DBS for people with essential tremor, the efficacy wore off. It's sort of counterintuitive that the efficacy of DBS for Parkinson's disease patients is maintained in the long term better than that for essential tremor, even though the essential tremor is by definition benign. It's called benign essential tremor. So the efficacy wears off, and as with any implanted system, inevitably there are going to be complications, whether it's infection or erosion of the hardware and so on. So now let's look at the history of functional radiosurgery, and I think it's of interest that this slide and a couple others later on were given to me by Dr. Evan Thomas, who is a radiation oncologist trained at the University of Alabama, currently on the faculty at Ohio State, but really currently he's serving in Iraq to fulfill his military commitment to the United States Army. But again, functional radiosurgery began with the very beginning of radiosurgery by Lexell, and then on to the Gamma Knife, which came online in 1968. But first described with LINAC by Antonio DeSalis. There'll be a lot of familiar names in this talk from the ISRS, and then with other systems for trigeminal neuralgia, and then thalamotomy described with a LINAC system by Leonardo Frighetto and Antonio DeSalis. So there's already a fairly long history of functional radiosurgery, although it's always played a somewhat secondary role in the world of radiosurgery on the one hand and functional neurosurgery on the other. So if you look at this sort of consensus review from 17 years ago, published out of Brown University, everyone understood by this point that there was a role for radiosurgery to treat trigeminal neuralgia and to do thalamotomies to treat tremor in people primarily with essential tremor, although perhaps for Parkinsonian tremor as well. And it's efficacious for that without too many side effects. But other methods or other diagnoses, that would be an experimental indication. Go ahead just 1 year. Here's a paper from UPMC with 26 patients who were graded rigorously pre and post stereotactic radiosurgical thalamotomy. And if you look here on the right, you could see that post Gamma Knife thalamotomy, the tremor was dramatically reduced in the majority of patients. So this has been established as an effective treatment for a while. So we have these treatments, DBS on the one hand, it's reversible, it's adjustable, it's basically safe, but it's got some potential long-term complications, limited efficacy for tremor over time. And on the other hand, we have radiosurgery, basically non-invasive, no maintenance required. So what is the role of lesioning? So DBS kind of ruled the roost since its approval in 1996, but all these issues, hardware complications and long-term benefit, have called that into question. And in the last 5 years or so, there's been a move in human neurophysiology to move towards a network-based model of the understanding of movement disorder pathology. And the more we move towards a network model, the more it supports the idea of making a lesion. Because if you interrupt the abnormal network, you have achieved your result. You don't have to stimulate a nucleus as such. And the fact is, radiosurgery does have a long track record of efficacy and safety for the relief of tremor. So now let's skip ahead into the sort of more contemporary era. This was a guidelines paper published by your very own ISRS 5 years ago. And again, you could see familiar names. The available evidence was class 4, single center cohorts, but you know what? Most neurosurgical and much radiosurgical advances have been made on these sort of studies, and there's nothing to be ashamed of for them. And the conclusion was that SRS is a good treatment for people who have failed medical therapy for the relief of tremor. And even if they are candidates for DBS, for invasive surgery, it still is a reasonable treatment to offer them. This is what the lesions look like in the medial thalamus using 4mm collimator. You have to aim it very precisely, and you should get that desired morphologic lesion and physiological result. And if we skip ahead a few more years from there, as work done by Joseph Niemat's group when he was at Vanderbilt. He's now the chair of neurosurgery at the University of Louisville. And the point that is made in this paper is that you have to be exquisitely accurate with the placement of your lesion in the thalamus. And if you do that, and if you really include the proper volume of the VIM nucleus, which is part of the ventrolateral thalamus, then you have a very good chance of having a responder for the treatment of tremor with radiosurgery. Back to the slides of Evan Thomas, and this reflects a growing interest amongst radiation oncologists in doing functional radiosurgery. And he makes the point in this slide that it doesn't have to be done with a gamma knife. And interestingly, he says historically on a gamma knife, but horrors, downside, it requires a stereotactic frame. Oh, that's terrible, because it means you have to actually get a neurosurgeon involved. But the fact is that in the University of Alabama, they did work with cone-based, LINAC-based radiosurgery with a variant edge, and they showed that you could achieve very tight treatment plans with tight dose gradients, and you could deliver 130 gray into the thalamus accurately. And this is a clinical study, as yet unpublished, but in the 32 patients, all but 3 of them had relief of their tremor with this cone-based, mask-based, not frame-based, mask-based LINAC thalamotomy for tremor. This shows the treatment plans in the thalamus. These are not the lesions as such. So this is all based from the preliminary study showing the physics accuracy of the plans. But this is a slide. I'd like to thank Marcus Breedel, going from UAB to be the chair of radiation oncology, University of Miami. And he's taking the treatment outcomes of the patients that had thalamotomies done at UAB and comparing them to the historical controls of those with focused ultrasound. And the fact is, if you compare that after 12 months of follow-up, their patients with the radiosurgical thalamotomy had a greater decrease in their tremor than patients who had focused ultrasound. Just a note of caution here. Want to point out, this is from a paper from Michael Oken's group, who's a well-known movement disorder neurologist from over 20 years ago, and I didn't outline these lesions. This is how they were published. But it shows what happens in so-called hyper-responders who were treated, in this case with gamma knife thalamotomy, and people had clinical symptoms as a result of these large lesions that resulted from standard SRS thalamotomy. And we had a great talk in the Gamma Knife meeting yesterday by Ian Paddock about the neoplastic risks of radiosurgery. This is an estimate from a chapter by Laszlo Steiner, one of the pupils of Lars Lexell and a leader in radiosurgery in the latter half of the 20th century. And he estimated like a 1 in 140 chance of a radiosurgery-induced tumor after 10 years. We know it's not that high. This paper from the Gamma Knife from Sheffield had 30,000 years of patient follow-up, and no one in that follow-up had a tumor. But we know it's not zero. So when we were treating benign conditions, non-anatomical conditions, the younger the patient is, we need to at least consider the risks of secondary neoplasia. Okay, so what about focused ultrasound? The new kid on the block. I know there was a lunch today sponsored by Incytec, and I don't know how many of the radiation oncologists here have had much exposure to focused ultrasound. And Lexell himself tried to use focused ultrasound to do radiosurgery. He abandoned it because there was no good technology for doing it. But now using a 1,000+ transducer array, you can focus ultrasound through the intact skull, if it's not too thick, and create a lesion in the center of the brain, in an envelope in the diencephalon, like maybe this big. So you can treat the thalamus, the anterior internal capsule, and maybe, if you're careful and you place your stereotactic frame accurately, the globus pallidus. Not necessarily. But this paper 11 years ago out of the University of Virginia, or led by UVA, showed in a randomized clinical trial that compared to sham treatments, focused ultrasound creating a thalamotomy was effective at relieving essential tremor. So in that time, since that time, the number of papers about focused ultrasound has really zoomed. And we treat patients with essential tremor at North Shore University Hospital with focused ultrasound. Here's the typical neurosurgical before and after video. You can see how bad this person's tremor is. Obviously, he can't draw a circle, let alone write his name, etc. And pretty much immediately after the thalamotomy, he's now able to do the circle and he can drink and all that. So that's all very good. And because there's no ionizing radiation involved, this has become a popular treatment. It's certainly in the United States and increasingly around the world. And the fact is you can do bilateral thalamotomies. This was always a knock on any sort of invasive lesioning procedure, radiofrequency, and also stereotactic radiosurgery. But this paper shows in a small cohort that you could do it safely. But look at this. This is a paper that came out a half year ago in neurosurgery, a meta-analysis comparing people who had radiosurgery or focused ultrasound to treat essential tremor. And you would assume, well, the essential tremor is going to win that hands down. But lo and behold, keeping in mind that there were many more patients with ultrasound than SRS still, after a year, the efficacy was similar, but the complications were higher, a lot higher in the patients who had focused ultrasound. And let's bring it back to the neglected child, DBS. The era of DBS is not over. Yes, we still have symptoms with big batteries, and you got to tunnel it to the chest and all that. But all that's going to change. Even within a few years, we'll probably have batteries that will be mounted in the skull, that will be permanently rechargeable from the patient's own energy, etc. So the hardware complications of DBS are going to decrease. And DBS is not going away. In fact, the number of patients getting DBS in the US has increased, if anything, over the last 30 years. I just want to briefly touch on other indications for functional neurosurgery for this audience, for obsessive compulsive disorder. Here's a series of papers that show that you can substantially improve the symptoms of OCD with deep brain stimulation for a variety of thalamic targets. But you could do the same with a gamma knife ventral capsulotomy. This is an IRRF paper that was published a few years ago. Again, you see familiar names. Let me get back to that on that paper. So the Yale-Brown obsessive compulsive score, that's the main score to measure OCD response. And you could see that there were good results there. But again, you could do it with focused ultrasound. It just barely makes it into that treatment envelope. There's a paper led by Jinwoo Chang from Seoul. The use of radiosurgery to treat pain syndromes in the thalamus is well described, and you could do this with focused ultrasound as well. But I don't want to belabor these points. And likewise, radiosurgery has been assessed as a way to control epilepsy, with efficacy not quite as good as temporal lobectomy. Side effects are similar, but it is non-invasive, and it is a good option for patients with certain types of medically refractive epilepsy. Okay, so what about comparing these methods of treatment for essential tremor, a nice focused kind of condition? So 3 years ago, this was stated by a well-known authority in stereotactic radiosurgery. With focused ultrasound available, I no longer recommend radiosurgery for someone with disabling tremor, for people who cannot or will not have DBS. Who was that? A melancholy Doug Konzioka. Now let's go ahead 3 years. Just 3 years. The complications of focused ultrasound persist in a high number of patients. It's time to reconsider radiosurgery as a non-invasive lesioning tool for tremor. Who is that? Neurosurgeons, you'll recognize this person. Andres Lozano. What? He's been going around talking about focused ultrasound for the last decade. And Dr. Lozano is one of the world's leading functional neurosurgeons, no question, but I don't think he knows a centigrade from a centipede. So in conclusion, the irreversibility of lesioning still argues for caution, especially in the era of deep brain stimulation. But for patients who cannot or will not have a DBS system implanted, lesioning is definitely a good option. The evidence does not clearly favor focused ultrasound over radiosurgery for tremor, Parkinson's disease, or obsessive compulsive disorder. And I'll put my marker down here. Radiosurgery with ionizing radiation, it's a safe and effective option for patients with a variety of functional disorders, but it should be led by neurosurgeons. Thank you.